Dr. Sarah Mayson. It's nice to meet all of you virtually. And I'm going to be speaking today about the diagnostic performance of molecular tests. I'm from the University of Colorado. I have no disclosures to report today. And our learning objectives are going to be review when molecular testing can be considered in the evaluation of thyroid nodules with indeterminate cytology. We'll again discuss the current molecular tests on the market and summarize and compare their performance characteristics, specifically speaking about their clinical validity. And then lastly, I'll give you a few examples of molecular test reports and how we can interpret these. So I always like to start with a case. So this is a 43-year-old male veteran, one of my patients, who has known history of hypothyroidism and a recently detected right thyroid nodule. He has no risk factors for thyroid malignancy or symptoms from his nodule, and his TSH is normal on levothyroxine. His neck ultrasound is shown, and this demonstrates a 3-centimeter right upper pole thyroid nodule. This would be considered ATA low suspicion pattern or ACR ThyRADS 3, depending on which system you prefer. And the patient has no contralateral nodules or abnormal lymph nodes. He undergoes FNA, and this shows Bethesda 4 cytology, suspicious for Hürthle cell neoplasm. So just take a moment to think about what you would want to do to manage this patient, or what you would consider when making that decision. And we'll jump right into it. So this slide summarizes the cytology diagnoses of the Bethesda system for reporting thyroid cytopathology and the predicted risk of cancer, NIFT-P, for each category, as well as the suggested management. As you will recall, indeterminate cytology includes Bethesda 3, 4, and 5 cytology. And prior to the advent of molecular testing, our usual management for these patients with indeterminate nodules was with diagnostic surgery. But as you all know, there are a number of costs associated with diagnostic surgery. Certainly there's the financial cost, but also around 60% of patients who undergo diagnostic thyroid surgeries get over or undertreated with the surgery that they receive. And of course, even with a lobectomy, there's a risk of postoperative hypothyroidism. In the current clinical practice, molecular testing is now commonly utilized as a rule-out test for thyroid cancer in the setting of Bethesda 3 and 4 cytology. And this has been shown to be a cost-effective approach in several studies, and particularly in countries like the United States that have higher costs of healthcare, particularly surgical and hospital-related costs. Because Bethesda 5 cytology has a much higher likelihood of being malignant, molecular testing is generally not used as a rule-out test for thyroid cancer because the negative predictive value associated with the negative test would be expected to be too low to be clinically useful. It's also always helpful to remind ourselves of the terminology that we use to describe test performance. Positive predictive value, as you will recall, is the likelihood that a positive result indicates that the disease, in this case thyroid cancer or NIFT-P, is present, while negative predictive value is the likelihood that a negative result predicts that the disease is absent. And you will also hear me speak about benign call rates today, and may not be as familiar with this term, but this is the percentage of tests that yield a negative result, such as in a particular study cohort. And if a particular test has a high negative predictive value, then the benign call rate will reflect those patients who are managed the same as those who have benign cytology. This figure shows an ideal molecular test, which has a negative predictive value that approaches that of negative cytology, paired with a positive predictive value that approaches that of malignant cytology. And based on the molecular test results, you can then triage your patient into 2 management groups, those who are followed clinically and those who undergo a therapeutic thyroid surgery. And also, when we think about any diagnostic test, it's also important to consider how that test was validated. And Dr. Nikiforova provided a wonderful summary of the analytical validation studies related to 3 tests that she discussed. And I'll just remind you that validation includes 3 components. So there's the analytical validation component, which has to do with the test's accuracy, reproducibility, and robustness. Clinical validation, on the other hand, assesses the accuracy with which the test predicts the disorder of interest, which in this case is thyroid cancer or NIFT-P. And clinical utility studies assess for the patient's benefit. For example, does utilizing molecular testing decrease the number of patients who undergo diagnostic surgeries? And lastly, when we think about test validation, it's also important to think about the scientific rigor with which the test was validated. A well-validated test is one that has been evaluated in multiple studies, including those that are prospective and multi-center, without industry sponsorship, and with pathologists blinding to the molecular results. I've summarized here in this table the 3 most commonly utilized molecular tests in the United States, although there are some others, and I'll be focusing my discussion on these today. I want to just mention the ThyGenX test, which Dr. Nikiforova also described. This platform, as she mentioned, is the only one that utilizes a microRNA component, the Thyrosq test, and it combines this with a test that the ThyGenX test, which involves next generation sequencing of DNA and RNA for select gene mutations and fusions. The microRNA classifier identifies nodules as having a low risk or a high risk microRNA profile, and the combination test utilizes a complicated algorithm that I won't get into right now that ultimately will yield either a positive, negative, or so-called moderate result. So 3 test result options. And here on this slide, I've summarized the quality of the evidence for the use of each molecular test that we've been speaking about today. I want to mention that the clinical validation study for the ThyGenX platform that I just mentioned was a multi-center study with pathologist blinding, but it was a retrospective and non-consecutive cohort that did not include medullary thyroid cancer or metastatic non-thyroid malignancies. It did not account for an IFT-P, and it also included a flawed calculation of test performance. In addition to this, to my knowledge, there have also been no published clinical utility studies assessing this test that were not industry sponsored. And so given the insufficient clinical validation of this test, I'm not going to delve into a more detailed discussion about it today, and will instead focus the remainder of the session talking about the other 2 tests. So this is the Afirma genomic sequencing classifier, which in contrast to its predecessor, the Afirma GEC test, which utilized microarray technology, GSC utilizes RNA sequencing to evaluate gene expression and then machine learned algorithms. As Dr. Nikiforova mentioned, upstream of the core classifier, there are components that can identify parathyroid tissue, medullary thyroid cancer, selected mutations and fusions associated with PTC, and in such cases, the core classifier is bypassed. The core classifier is called the ensemble model, and this includes a follicular content index, and is actually again, an ensemble of multiple classifiers, including 2 classifiers that are focused on Hürthle cell nodules in order to improve the test's overall performance. One of the limitations of the GEC test was that there were a high number of false positive tests in the presence of Hürthle cells, not necessarily predicting Hürthle cell neoplasms. And the new classifiers help to better differentiate between true Hürthle cell neoplasms and non-neoplastic Hürthle cell lesions, since Hürthle cells can be seen in truly benign hyperplastic lesions as well. The reported result for the Afirma GSC test is binary. Either a suspicious or positive result will be reported, or a benign or negative result. This is the industry-sponsored multi-center blinded clinical validation study for the Afirma GSC test that was published in 2018 by Patel and colleagues. And this study used samples from the prospective GEC validation cohort. An adequate sample was available for 191 of the 210 lesions from the original GEC cohort. And histopathologic diagnoses were determined during the previous GEC trial, and thus the prevalence in IFT-P was not able to be determined in this study. The specificity of this test was notably higher at 68% compared to GEC, predominantly related to those new Hürthle cell classifiers that I mentioned. And the cancer prevalence in this study is slightly lower than GEC because it did not include Bethesda 5 cytology and the determination of test performance. And the overall negative predictive value was 96%, positive predictive value 47%, and the benign call rate in the study was 54%. This figure shows the NPV and PPV for the GSC tests that I just mentioned for Bethesda 3 and 4 nodules in combination. And this is where the disease prevalence was 24% overall. However, I want to point out that it's important to consider how this test will perform in populations with a higher prevalence of disease. because we know that negative predictive value decreases as prevalence rises. A negative predictive value of at least 95% is considered desirable for a molecular test to be utilized as a rule-out test for thyroid cancer in clinical practice. And when we consider Bethesda 3 and 4 cytology separately, the negative predictive value of GSC does not appear to be sufficiently high to use with Bethesda 4 cytology once disease prevalence exceeds 23%, as calculated using Bayes' theorem. In such cases, it'll fall below 95%. This is a relevant consideration in clinical practice since the expected likelihood of malignancy or NIFT-P for Bethesda 4 cytology is between 25 and 40%, as I showed on an earlier slide. And thus a negative GSC test result may not reflect a post-test probability of malignancy of 5% in some populations of Bethesda 4 nodules. This figure summarizes the clinical utility studies, some of the clinical utility studies that have been published evaluating GSC. The benign call rate with Bethesda 3 and 4 nodules in these 3 independent studies ranged between 53 and 80%, and overall was higher for Bethesda 3 than before cytology, as one would expect. And only 1/3 of nodules or less were resected in these studies. This figure, on the other hand, compares the benign call rate of GSC to its predecessor GEC. And you can see that the benign call rate of GSC was substantially higher in all of these studies. The Cleveland Clinic study that I have listed here observed a 13% absolute reduction in thyroid surgeries at their institution after they adopted using GSC in 2017. Prior to that, they primarily utilized GEC. I also want to mention briefly Expression Atlas, which Dr. Nikiforova previously discussed today. The manufacturer recommended application for this test is to help inform management decisions such as the extent of surgery for indeterminate thyroid nodules, or this test can alternatively be used with for testing in known thyroid cancers, such as in cases where genetically targeted therapies are being considered. This there was an industry-sponsored validation study that Dr. Nikiforova mentioned earlier, and this demonstrated that approximately half of malignancies from the AFIRMA GEC/GSC validation cohort harbored gene variants or fusions that could be detected through RNA sequencing. But it was found that Expression Atlas itself did not significantly affect how the GSC test performed, meaning that it didn't significantly impact the positive predictive value of a positive GSC test. And as Dr. Nikiforova described earlier, there are certain genetic alterations that cannot be detected through Expression Atlas, since this is an RNA-based test, including copy number alterations, but also mutations in non-coding regions of DNA, such as the TERT promoter variants. I'd now like to move on to speaking about the Thyrosiq GC, or version 3 genomic classifier. The first step in this test is an assessment for quality assurance to ensure there's sufficient cellularity, and then an assessment of the cellular lineage. And this can detect thyroid follicular cells, parathyroid cells, C cells, as well as non-thyroidal cells. And samples that qualify would then be analyzed for 4 different classes of genetic alterations in 112 genes. And as mentioned earlier, mutations can be detected, as well as gene fusions, copy number alterations, which we see more frequently in Hürthle cell nodules, and then also gene expression alterations. And the test result interpretation is based on a molecular database. And the overall result that's yielded is a positive or negative result, but also a detailed genomic report that describes what genetic alterations were detected, if any were. The Thyrosiq GC test was evaluated in a clinical validation study that was non-industry sponsored, prospective, multi-center, and double-blinded. And this included 10 clinical sites, one of which was international. Central pathology sample review by a panel of 3 thyroid pathology experts was included. And the final study set included 286 Bethesda 3, 4, and 5 nodules, 257 of which had informative molecular testing, meaning a sufficient sample for molecular testing. And 8.2% of nodules in this cohort had GC scores of 1, which means that they harbored low-risk genetic alterations that alone are thought to be very low risk for the development of a malignant lesion. And commercially, these are reported as currently negative, and in this study were considered negative results. The diagnostic accuracy of this test was calculated for Bethesda 3 and 4 nodules only, and the sensitivity was determined to be 94%, specificity 82%. In this study, the cancer NIFP prevalence was 28%, and thus the negative predictive value of the test in this population was 97%, positive predictive value 66%, and the overall benign call rate was 61%. I did want to mention that there were 11 NIFP nodules included in this study, and all were classified as positive, which is appropriate. This figure shows the negative and positive predictive value of Thyrosiq GC separately for Bethesda 3 and 4 nodules, and this is mapped against excuse me, disease prevalence. This lists on this figure the disease prevalence for Bethesda 3 and 4 nodules from the clinical validation study, 23% for Bethesda 3, 35% for Bethesda 4. And I wanted to mention again that it's important to consider how the test will perform when disease prevalence is higher, because we know that negative predictive value decreases as prevalence rises. And using Bayes' theorem, again, you can see that the negative predictive value of this test should remain 95% or higher for a disease prevalence of up to 40% in Bethesda 3 nodules and up to 60% in Bethesda 4 nodules. And thus, based on the clinical validation study, Thyrosiq should perform well as a rule-out test for thyroid cancer, even in populations with a disease prevalence at the upper end of the expected range for both Bethesda 3 and 4 nodules. So I'm just gonna have some water break. So one of the other advantages of the Thyrosiq test and tests like this is that you can receive also information about the molecular alterations that are detected by the test. We know that different molecular alterations are associated with different likelihoods of malignancy or NIFP and different tumor types, as Dr. Nikiforov presented earlier. For example, BRAF-like mutations were malignant 100% of the time in this study and most commonly represented classic PTCs. The RAS-like group included RAS mutations, BRAF K601E mutations, among others. And nodules with these molecular alterations, as you recall, can be benign or malignant neoplasms. And overall, 60% of the RAS and RAS-like nodules in the study were cancer and NIFP. The high-risk group listed up top includes nodules that have TERT mutations and other high-risk genetic alterations. And these are associated with a very high probability of likely high-risk cancer, particularly when these are seen in combination with other gene variants such as BRAF V600E. Copy number alterations, as you will recall, are found typically in Hürthle cell neoplasms, although you can see them in follicular neoplasms as well, and other tumors. And gene expression alterations can be seen in a number of different tumor types, including medullary thyroid cancer. This figure summarizes the benign call rate with Bethesda 3 or 4 nodules for 3 studies that assess the clinical utility of Thyrosiq GC. The benign call rate ranged from 48 to 82% in these studies and was again higher for Bethesda 3 than Bethesda 4 cytology, as you'd expect. And about 1/3 to 1/2 of nodules were resected in the studies. I did want to mention a little bit about Thyrosiq testing on FNA smears, which Dr. Nikiforova also mentioned. This was a study which she led where they assessed 31 smears for Thyrosiq testing. This included 14 pap smears, which are alcohol fixed, and then 17 air-dried Diff-Quick smears. And they found that there was better preservation of nucleic acid with the alcohol fixed smears than the air-dried smears, where 100% of the pap smears were adequate for genomic analysis, while 25% of the Diff-Quick smears failed RNA sequencing. And overall, there was a 98% concordance between the smears that were tested and samples from fresh FNA. And so in conclusion, if it's available to use a fresh FNA sample, this is likely remains preferable, but smears are a wonderful option for molecular testing when a representative fresh FNA sample is not available, or perhaps the fresh FNA sample that's available is not thought to be representative of the lesion of interest. I did want to mention that This type of testing can also be performed with the ThyGenX test that I mentioned earlier, as well as a couple of other tests that are available worldwide, but not in the United States. I'd like to wrap up our discussion now by reviewing a recent prospective randomized trial from UCLA Medical Center that compared the performance of the Thyrosiq and the Afirma tests. And this was mentioned earlier in a discussion, the analytical validity by Dr. Nikiforova. This was a parallel randomized controlled trial where on alternate monthly basis, they either utilized the Afirma or the Thyrosiq tests. And this particular study included 372 thyroid nodules with Bethesda 3 or 4 cytology, 189 patients, and 201 nodules were included in the Afirma cohort, and then 157 patients and 171 nodules were included in the Thyrosiq group. In this study, as well as most clinical utility studies that evaluate the performance of molecular tests in the real world, nodules with negative molecular tests are presumed to be true negatives based on the molecular test result, and they're managed as such, typically without surgery. So patients who have negative molecular tests, usually we follow them clinically unless there's some compelling clinical indication for surgery, such as a change in the appearance of their ultrasound, the development of new symptoms, and so forth. And this is a very appropriate in the setting of a clinical utility study reflecting real world practice, but importantly, it does limit the detection of false negative cases. And I wanted to mention that overall 12 nodules in the in the Afirma group and 10 in the Thyrosiq group underwent surgery in this study. So those are among the ones that had negative molecular testing, whereas the nodules that had positive molecular testing went to surgery. And the specificity of the Afirma test I wanted to point out was somewhat higher than that which was determined by the clinical validation study by Patel. So it was 80% versus 68%. And the specificity of the Thyrosiq test was modestly higher than the Afirma test in this study, but there wasn't a statistically significant difference between the two, nor in their sensitivities, negative predictive values or positive predictive values. And the benign call rates for both tests were very similar to what was determined in their respective clinical validation studies, as I've shown on this slide. And overall, about 50% of patients were able to avoid diagnostic surgeries in this study. And so I'd like to take the last few minutes of this session to circle back to the beginning where I mentioned a case. As you recall, this was our 43-year-old veteran who had undergone FNA and was found to have Bethesda 4 cytology. And this is the patient's Thyrosiq report. And I just want to spend a few moments looking at his report and talking you through all of the details that are included. So the first thing that I wanted to point out is that this includes an assessment of specimen cellularity and adequacy. And again, this reports in my particular patient's case that this was adequate. And then the overall test result, which was positive. And if I'll draw your attention to the lower portion of the screen, this shows that the reason that the test was positive. And so in his case, gene mutation and KRAS mutation was detected, as well as abnormal gene expression. And so overall, this would denote a probability of cancer in NIFT-P that's between 50 and 60%. And there's a detailed interpretation that describes why, sorry, not why, but more details regarding that and what types of tumors are typically associated with this particular result, and then a potential management strategy as well. But I'd like you to consider for a moment an alternate reality where the results of the patient's test not only showed the KRAS mutation and the abnormal gene expression, but also copy number alterations and a mutation in the TERT promoter. And this is actually the Thyrosiq report from a different patient, but I think it's interesting to consider how these results would affect the patient's prognosis and potential management. So on the left-hand panel, I illustrated here the likelihood that different types of neoplasms that you'll see in the setting of isolated RAS mutations. Up to 50% of tumors in this setting will be benign adenomas, 25 to 30% NIFT-P, and the remainder are malignant. But most cancers, as Dr. Nikiforov pointed out earlier, that have isolated RAS mutations can be low-risk follicular pattern tumors like follicular variants of PTC, and appropriate management in most cases with these isolated RAS mutations is with a lobectomy. In contrast, multiple studies have demonstrated that tumors with combined mutations with TERT and RAS or TERT and BRAF V600E have higher rates of distant metastasis as well as decreased disease-free survival. And thus, in the alternate reality that I presented to you, you should consider more aggressive management for your patient, such as with a total thyroidectomy, given his likelihood of aggressive thyroid malignancy. And then lastly, although AFIRMA testing was not performed in this particular patient, I wanted to go through one of their test reports. So on the left is the results of the AFIRMA genomic sequencing classifier. And as I mentioned earlier, this is when you're ordering this test, you can add on AFIRMA expression atlas, but that component is not automatically included. And insurance variability may vary for expression atlas, so it's something that's important to look into as well when ordering the test. For AFIRMA GSC, again, this will yield a positive or negative result. In this particular case, it was suspicious for malignancy and denoted a risk of malignancy of about 50%. And there's a notation that medullary thyroid cancer and parathyroid tissue was not detected. And then just to mention the AFIRMA expression atlas result, this lists the gene variant that was detected, BRAF K601E in this case, the risk of malignancy associated with that, which is approximately 50%. And they list in this report also what the clinical relevance of this mutation is, as well as the associated tumors that can be seen, and also indicate if there's an FDA-approved therapy that's available that can target this particular mutation. And so in conclusion, I want to say that well-validated molecular tests that have a high negative predictive value, such as the AFIRMA and Thyrosiq tests that I've reviewed here, serve as robust rule-out tests for thyroid cancer. Keep in mind that negative and positive predictive value are influenced by disease prevalence, and as disease prevalence rises, the negative predictive value will decrease. It's important to consider how a higher disease prevalence will reflect the reliability of a negative molecular test result, particularly with Bethesda 4 cytology, which generally has a higher prevalence of disease. And I mentioned this earlier when I was describing the AFIRMA test. Molecular tests that yield specific genomic information can be useful to help inform prognosis and determine management in constellation with the clinical findings for the patient and their preferences and so forth. And then lastly, long-term follow-up studies of nodules with benign molecular testing are still needed. We have these for some of the older versions of these tests, but not for the current versions.